Dear distinguished speakers, dear ladies and gentlemen, we welcome you to the International Online Symposium on SARS-CoV-2, organized by the Postgraduate Programme, Healthcare Management, and we thank you for your online presence. The aim of this symposium is to address the SARS-CoV-2 pandemic. The different interventions to reduce its effects and its multifaceted impact on human rights, private and public health, mental health, and public health in general. Invited speakers are the following academics and doctors: Associate Professor Elpidoforos Soteriades, MA in Healthcare Management, Open University of Cyprus; Dr. Atanas Mangarov, Associate Professor of Pediatric Infectious Diseases of the Medical University of Sofia; Dr. Lambros Lazuras, Associate Professor of Psychology of Sheffield Hallam University; Dr. Sucharit Bhakdi, Professor Emeritus, Medical Microbiology and Hygiene, Johannes Gutenberg University, Mainz; and Dr. John Ioannidis, Professor of Medicine, Epidemiology, and Population Health of Stanford University. Metropolitan Isaias of Tamassos and Orini will open the symposium, while Andreas Giannopoulos, cardiologist, and Dr. Pendros Agathangellou, President of the Pan-Cyprian Medical Association, will give their introductory remarks. Before we start with the proceedings of this e-symposium, we would like to raise your attention to the following. The symposium will be recorded. All participants will have closed microphones and cameras, and questions and answers will take place after the presentations according to the program of the event. You may use the chat on YouTube, if you're watching us on YouTube, or Blackboard to raise any questions, mentioning who you wish to ask during the Q&A sessions. And without further ado, we now give the floor to Metropolitan Isaias of Tamassos and Orinis for the opening remarks of this conference.
Good evening. My name is Father Nicholas Doumas. I'm working at the Secretary of the Office of Metropolitan. With the emergence obligation of Metropolitan, I will read his greeting and I transfer the wishes for the success of this symposium. Reading of the Most Holy Metropolitan of Tamassos and Orinis, Mr. Isaias, to the International Electronic Symposium on SARS-CoV-2. I cordially address the organizers and participants of this scientific symposium, focusing on the research findings of the current SARS-CoV-2 epidemic, which has spread throughout the whole world. This pandemic, which broke out during the last few months, knows no borders and does not visit people on a selective basis. It discriminately affects everyone, ascending geographical borders and imposing risks on every person of every age, for infancy to the elderly. Furthermore, it immediately causes both anxiety and panic, because the medical community cannot be able to develop effective treatment to fight this new coronavirus. The problem is not only the danger from this virus, which causes fear and occasionally may lead to severe complications and fatalities. Moreover, it is complicated by the negative consequences from the strict control measures enforced that have a direct impact on the economic, social, educational, as well as all over the aspects of personal, community and public life on a national and global scale. In addition, the virus and its associated control measures serve as a catalyst of the entire human life in our societies. It is for this reason that people around the world are experiencing a state of physical and mental repression, if not a feeling of their freedom being attacked, with the untapped consequences of negative psychological states, phenomena that are being observed at different levels in the society. However, in my communication to you, I will declare that, contrary to some people's beliefs, in my view, the coronavirus pandemic is not an expression of the divine punishment. This cannot be accepted because God is love and only love. God, according to the Bible, is infinitely bad. He cannot be bothered. Yes, God's love for man is immeasurable. God is the Father of the people, of all people, and all people no matter where or who we are, belong to God's great family. We are all His children. Therefore, the view that God is the counsel of evil in man is beyond any godly meaning. However, let me point out something very important and real, that despite the infinite magnitude of God's love and care for man, unfortunately, man's love for God is inversely disproportionate. While God loves more, we love Him in defeat or not at all. Not to mention that some people turn out to be atheists, or even worse, of all stand opposite God. But with this attitude, we rebuild and raise the Tower of Babel, that is our ignorance of God and our worship of the proper magnitude of our selfishness, with all, of course, negative consequences. People today exaggerating the height and size of the qualifications of their mind, but God, on the sidelines or in the position of the denominator, this shows His whole reversal and propose all the cells as numerator or regulator of their life. Not to say that He propose a self-image instead of God. Nowadays, people are inevitably facing the spectrum of a threat and are asked to deal with an invisible, with naked eye and trivial virus. They stand embarrassed and ecstatic, infected by the virus and unable to deal with it. In modern superhuman lives, his self-humiliation, to remember Nietzsche. It is as if this tiny enemy is telling us, you are powerless to face my vicious behavior. At this point, please allow me, without a teaching mode, to submit due to my capacity as hierarch, my personal opinion and suggestion. But in the present need, God is extremely necessary for us. In my opinion, this is true for too many reasons. First, God is needed to strengthen and support our paralyzed needs from fear, and above all, to enlighten the minds of our scientists, so that they will be able, with the appropriate methods and the necessary antidotes for the treatment of SARS-CoV-2. And here comes precisely the coaxial scriptures. It says that God gave the science of physicians, but Christ, in His earthly presence, always showed the compassion to those who they needed and asked for His help. I will conclude to stress emphatically that I'm personally optimistic, because I invest in the love of God and the prayers of our heavenly and earthly saints, since the prayer of our saints will attract God's mercy and compassion, so that we may escape the current deadlock and enjoy a new period of freedom, comfort, and happiness. The Bishop of the Metropolitan of the Atanas, Ioannidis, Mr. Isaias.
Thank you very much for these opening remarks. And we will now give the floor to Dr. Andreas Yannolopoulos, cardiologist of Nea Erythrea Attica in Greece, for his introductory remarks. Dr. Yannolopoulos, you have the floor. Dr. Yannolopoulos, can you hear us? You can open the audio and give your opening remarks. Thank you. Dr. Yannolopoulos? Okay, perhaps we can continue if we have Dr. Petros Agathangelu with his opening remarks. Dr. Agathangelu is the president of the Cyprus Medical Association, so you may start with your own talk. Thank you.
Okay, am I heard? It's okay?
As we can hear you and we can see you, yeah.
Distinguished participants, colleagues, on behalf of the Cyprus Medical Association, I would like to express my sincere appreciation towards the Faculty of Economics and Management of the Open University of Cyprus for the kind opportunity to address the very interesting international symposium on SARS-CoV-2, and thank the organizing committee and my friend Elpidoforos Soteriades for inviting me. We do know that COVID-19 outbreak is affecting everyone worldwide. Policymakers, scientists, and medical practitioners are exploring uncharted territory while trying to get the grips within this new virus. Current efforts aim to strengthen coordination between academic, scientific, and operational parties on combating the pandemic. The Cyprus Medical Association is committed to the safety and well-being of our community. The authorities have this responsibility to offer safe working conditions to doctors and health workers at the front line. Adequate personal protective equipment needs to be fully available, and services need to be considered that require sufficient number of personnel so as not to expose one another to bigger risk of being infected. We also focus on the importance of sharing knowledge. The COVID-19 has painfully reminded us that nobody anywhere in the world is safe from high infectious diseases. There is enormous effort from scientists worldwide to expand the knowledge with regards to the pandemic, and hopefully we will come up with effective medical management, therapeutic management algorithms soon. Furthermore, the ongoing pandemic is already affecting economies, everybody's professions, and our workers, physicians as well. That's why we talk about a new normality in our day-to-day practice of medicine. Different forms of telemedicine and the utility of remote work are tested during the extraordinary situation the whole world is experiencing since the outbreak. We are facing an extremely serious challenge. Our aim is to stay focused and to be prepared to manage the situation during upcoming winter season. We doctors are determined to contribute on a scientific base towards the direction of effectively controlling the pandemic. Dear colleagues, ladies and gentlemen, I would like to extend a very warm welcome to the distinguished speakers of the symposium. Let me also convey to you the most sincere welcome by the Council and members of the medical community of Cyprus, together with the assurance that we will continue to support such events. With these few words, I would like to wish you all beneficial and productive session. Thank you.
Thank you very much, Dr. Agathangeliou. We will now see if Dr. Andreas Giannoulopoulos can join our session for his opening remarks. Dr. Giannoulopoulos. Can you hear us? There seems to be a problem with Dr. Giannoulopoulos. Therefore, we will continue with the first presentation of this day. We welcome to the floor Dr. Elpidoforos Soteriades, Associate Professor of Epidemiology and Public Health at the Open University of Cyprus, who will give his own talk on human rights, public health, and the new vaccine in preparation for SARS-CoV-2. Dr. Soteriades, you may have the floor. Dr. Soteriades.
Good afternoon, everybody. Thank you for joining our symposium, and I hope that the presentations from our distinguished speakers will help internationally to more effectively manage this current epidemic. I would like to focus my talk on human rights, public health, and the issue of vaccine. I like to use some short sayings to begin my talk. Silence is the voice of complicity. We hope that this dialogue will help our scientific exchange in order to move forward with this problem. Hippocrates, the father of medicine, has been an international figure on excuse me, can you see my presentation? Just give, I'm sorry, just give me a moment. I don't know what happened. Yes. Yeah, I was saying that Hippocrates, the father of medicine, has been a celebrated figure throughout the centuries for his contributions to medicine and for his important writings on different topics. However, one of his famous writings is the Hippocratic Oath, which is still being used today by medical schools around the world. And one of the most important sayings of his Hippocratic Oath is first, do no harm. And I think we need to keep this in mind as we strive to face this new epidemic. And I would like to review briefly the Universal Declaration of Human Rights, which was published in 1948 as a result of the atrocities seen by humanity in the Second World War. And the General Assembly of the United Nations proclaimed that the Universal Declaration of Human Rights should be a common standard of achievement for all peoples and all nations, to the end that every individual and every organ of society, keeping this declaration constantly in mind, shall strive by teaching and education to promote for his rights. If we look at the article, at the first article, says that all human beings are born free and equal in dignity and rights, and everyone is entitled to all rights and freedoms set forth in this declaration without distinction of any kind, such as race, color, or other characteristics. In Article 12, we read that no one shall be subjected to arbitrary interference with his privacy, family, home, or correspondence, nor to attacks upon his honor and reputation. And everyone has the right to freedom of movement and residence within the borders of each state. Article 18 says that everyone has the right to freedom of thought, conscience, and religion. And this right includes the freedom, either alone or in community with others, and in public or private, to manifest his religion or belief in teaching, practice, worship, and observance. Furthermore, Article 19 says that everyone has the right to freedom of opinion and expression, and this right includes freedom to hold opinions without interference, and to seek, receive, and impart information and ideas through any media, and regardless of frontiers. Article 20 says that everyone has the right to freedom of peaceful assembly and association. And Article 26 claims that everyone has the right to education. Education shall be directed to the full development of the human personality and to the strengthening of respect for human rights and fundamental freedoms. as we read all these articles, including Article 27, which says that everyone has the right freely to participate in the cultural life of the community, to enjoy the arts, and to share in scientific advancement and its benefits, we see that many of these fundamental human rights have been violated during these past few months in an attempt to manage this epidemic. And I would like to stress the importance of the last article of the Universal Declaration of Human Rights, Article 30, which says that nothing in this declaration may be interpreted as implying for any state, group, or person any right to engage in any activity or to perform any act aimed at the destruction of any of these rights and freedoms set forth herein. Therefore, Article 30 proclaims that no one has any right to violate these rights included in the Universal Declaration of Human Rights. And we need to remember as well the Nuremberg Code, which came about the same time in 1947 during the Nuremberg trials for the atrocities of the Second World War, which states explicitly that the voluntary consent from patients is required for any intervention in medicine. The World Medical Association, the Helsinki Declaration, which was published in 1964, has many articles, and its general principles claim that physicians should put the health of patients as their first consideration, and also say that a physician shall act in the patient's best interest when providing medical care. Furthermore, it claims that it is the duty of physicians to promote and safeguard the health, well-being, and rights of patients, including those who are involved in medical research. Therefore, we as physicians around the world have a duty, according to the Helsinki Declaration, to stand for the rights and freedom and health and well-being of our patients around the world. If we remember this famous, in a negative way, the Tuskegee study in Alabama, USA, which was performed for a period of 40 years from 1932 to 1972. This was a negative example of violating patients' rights by not providing treatment to these syphilis patients for a period of 40 years while the treatment was available. As a result of this problem, the federal government of the United States convened a committee to try to develop a guiding document in order to prevent these events from happening again. And in 1979 came the Belmont Report, this famous report in the United States, which claimed that any research being performed should observe three major values, which is respect for persons, beneficence, and justice. And under these three major core values for medical research, there have been developed several guidelines, including the widespread use of consent forms for any invasive medical care or any participation in research which involves humans, as well as under the beneficence value, everyone has to assess the risks and benefits of any intervention. And under the third major value of justice comes a long document of guidelines about the selection of subjects to participate in medical research. The Alma Ata Declaration was another major milestone in this constant search to improve the health of people around the world. And Alma Ata was a city in the former Soviet Union where the WHO, the World Health Organization, convened a major conference in 1978 to proclaim that primary health care was the vehicle through which we would provide access to healthcare for all. And this conference was repeated 40 years later in 2018 in the same city, which was now renamed as Astana city in Kazakhstan, and where people reaffirmed and reassured that primary health care should be an inclusive, community-led, multi-sectoral approach to promoting population health and preventing illness, as well as a means to provide curative and rehabilitative services. Under this same declaration, which came in 2018, the WHO claimed that the people have their right and duty to participate individually and collectively in the planning and implementation of their healthcare, meaning that they should have control over their healthcare in a bottom-up approach. As we review all these human rights declarations, we realize how many times during the past few months all these human rights and all these core values have been violated in order to try to control this epidemic. However, public health is also a major field that has the ability to inform us on how to face these difficult times. Pioneers of public health include Charles Edward Amory Winslow, who is considered one of the major figures in the field of public health. He lived in the previous century, in the 20th century, and he was the first to establish the first Department of Public Health at Yale University, which is now the School of Public Health at Yale University, and has given the definition of public health which stands even today, saying that public health is the science and the art of preventing disease, prolonging life, and promoting physical health and efficiency through organized community efforts for the sanitation of the environment and so forth. And therefore, we realize that public health is the art and science which includes all organized efforts of the society, whether public or private, aiming to prevent disease, promote health, prolong life, and improve quality of life among the population as a whole. Public health is a big umbrella under which we see that we include both prevention and treatment, environmental health, occupational health, and public health has several core values as well. In a European health report about the core values of health, which was published this year, 2020, they claim that in order to achieve health for all, we need to observe and follow a lot of core values, including transparency, community resilience, supportive environments, enabling environments, a whole of society approach, participatory governance, responsible governance, accountability, a life course approach to the health problems of people, empowerment, and a people-centered health systems. If we review all these core values, we realize how much we failed to observe all these core values during these difficult times of the epidemic. And I would like to focus on two of these core values of public health, one of which is community resilience, the ability of community to recover from difficulties. And community resilience involves uncovering community strengths, such as social networks, civic activism, and at the same time suppressing vulnerabilities such as social isolation in order to mobilize a community to recover from adversity. Key indicators of this definition include social networks, family support, and civic participation. How much this community resilience has been ignored during these times of the coronavirus epidemic. Another core value is empowerment, meaning that we need to enable individuals and communities to increase control over their lives in order to achieve a better health status, which is considered a prerequisite for health. Public health practice, of course, has its own values, two of which include justice and participation. Justice is a value where we need to observe in order to balance the burden and benefit among segments of the population. And of course, social participation is characterized by informing, consulting, involving, collaborating, and empowering people in order to have a cooperative approach to health problems. Again, how much have we observed all these core values of public health in these dire times of the coronavirus epidemic is a major question. And in these contested views on the relationship between citizens, the state, and science, we need to keep in mind that citizens should always be highly weighted over the power of the state, and at the same time, science should be utilized in order to enable citizens to face their problems in the field of health and public health. And of course, I would like to remind a lot of you about the basic characteristic of the basic characteristics of clinical trials and experimental studies, where we specify a hypothesis either in the field of prevention or in the field of treatment, and we develop a scientific proposal and obtain ethical approval from ethical committees. And we need to consider this equipoise, this scientific dilemma where we need to balance between burden and benefit. We need to consider the uncertainties about risks and benefits of specific treatments or interventions. And in order to consider these equipoise, we need to have a sufficient expected benefit from a specific treatment or in social intervention. And at the same time, we need to have a sufficient doubt to withhold treatment from some people in order to be ethically justified to implement a specific experimental treatment in the population. And I'm talking about this because I think that these same values, these same methodological approaches apply not only for clinical studies, but also for social interventions. And we have seen so many measures being implemented in the society without taking into consideration these basic values that have to do with experimental studies. And in order to consider this, we need to have in mind that there is always a balance between research and practice, and whether practice should be informed and guided by research. In the few past decades, we all talk about evidence-based medicine or evidence-based interventions. And I think we need to keep this in mind because, in my opinion, many of the interventions we have seen being implemented on a societal level lack scientific evidence at this point in time. Therefore, having in mind all of these that we have reviewed, both in the field of human rights as well as in the field of public health, we need to consider the current discussion, scientific discussion that goes on regarding the vaccine that's under preparation, and everyone is talking about and waiting for this magic vaccine to come and save us from the virus. What we know so far is that there are many vaccines in the making for SARS-CoV-2 and are being prepared by different companies around the world. Most teams working on these new vaccines engage with a new biotechnology approach in order to develop these vaccines that has been used for the first time and refers to the so-called genetic vaccines that will include genetic material such as RNA and DNA. We need to keep in mind that this new technology for developing vaccines has not been previously used, and we have no experience of this technology being used in humans. And we need to keep in mind that there are some studies in animals that have shown serious side effects from these genetic vaccines, including chronic inflammation, myopathy, neurological problems, as well as several autoimmune diseases. And in fact, we have seen these autoimmune diseases to manifest in some of the volunteers participating in the current phase 3 trial of the vaccines under evaluation. Furthermore, the studies regarding the evaluation of safety, efficacy, and effectiveness of the new vaccines are being performed with unprecedented rush, leading to justified concerns from scientists, health professionals, and the public about their potential credibility. The current arguments for implementing mandatory vaccination programs, as well as building artificial immunity using vaccines, in my opinion, violate ethical, epidemiological, and public health principles. Serious side effects of the new vaccines that are under question may be more frequent than the actual complications of the natural infection from the coronavirus when we talk particularly about children and young adults. In addition, if vaccines exhibit a reasonable safety and effectiveness, then the health of vaccinated individuals will not be threatened by others who choose not to receive the vaccine, therefore abolishing the arguments about mandatory vaccination for all. Furthermore, people are entitled to universal respect of human rights, and they are free, non-coerced decision to provide consent and receive invasive medical interventions, including vaccination. In summary, I would like to say that human rights must be observed by all, including governments around the world. The ongoing epidemic cannot be considered a justifiable reason to violate human rights, and any current violations should cease. Core public health values need to be respected and remain in the center of public health approaches and interventions for implementing control measures for the epidemic. The continuous struggle between citizens, the state, and science should always be weighted and respect people's autonomy over state power. And vaccines under development for SARS-CoV-2 need to be scrutinized for their safety and effectiveness with full transparency under the most rigorous scientific methods. In conclusion, I would like to claim that there is no medical, epidemiological, or any other reason that can be used to support a mandatory vaccination program in the population. The medical community should uphold its highest ethical standards and protect the health of individuals and communities alike. The core values of public health argue against a mandatory vaccine program, which may cause more harm than benefit, particularly among children and young adults. And vaccines that are currently in phase 3 evaluation process have not included children in their volunteer population. Therefore, are not justified to be given to children, even if they are licensed by appropriate authorities under emergency circumstances. We, as scientists and public health professionals, must call for all governments to respect scientific knowledge and implement evidence-based measures to protect the public from the coronavirus. We, as public health professionals, must call for all governments around the world to unconditionally respect human rights and uphold and incorporate all core public health values in their approach to control the current epidemic. Thank you very much for your time and patience.
Thank you very much, Dr. Soteriades. We will now give the floor to Associate Professor of Pediatric Infectious Diseases of Medical University of Sofia, Dr. Atanas Mangarov, for his own presentation on the topic of coronavirus infection amongst children and their influence on the current epidemic. Dr. Mangarov, you have the floor. Thank you.
You hear me? Is it okay?
We can hear you, yes.
Okay. So my short presentation will be about COVID-19 in children. We have much of a problem with COVID. I don't know. But the virus probably has been created in such a way that it does not affect children, unlikely influenza virus, which mostly affects young children. In most of the kids, the infection with the disease is not so severe as in the adults. Most children have just mild symptoms or no symptoms. I've seen plenty of children with COVID up to now, and no one has been ill. Those who have been admitted to hospital go crazy when children catch or are proved to have COVID-19. Represent about 10% of all COVID-19 cases. Research suggests that children younger than ages 10 to 14 are less likely to become infected with the virus that causes COVID-19 compared to people aged 20 and older. Hospitalization rates for children are also much lower than for the adults. This is probably because in most cases children are asymptomatic and they are not being tested, and without tests you cannot prove that someone has or does not have COVID-19. Why do children react differently to COVID? The answer isn't clear yet. Some people suggest that children are not so severely affected by COVID-19 because there are other coronaviruses, cause diseases such as the common cold. You know that about 10 to 15% of viruses that cause common cold are coronaviruses. And since children often get colds, this is the right word, their immune system might be primed to provide them with some protection against COVID-19. But these are just suggestions. It is also possible that the children's immune system interacts with the virus differently than the adults' immune system. May I have the slide, please? I don't see the slides. Okay, thank you. Sorry. But it is also possible that children's immune systems interact with the virus differently than the adult immune system. The immune system seems to overreact to the virus, causing more damage to their bodies. This may be less likely to happen in children. But already know the COVID-19 virus affects mostly adult elderly people, while flu virus affects mostly children. How about the newborns? Newborns can become infected with the virus that causes COVID-19 during childbirth or by exposure to 6 caregivers after delivery. To protect newborns from infection, good hygiene should be provided. And research suggests that only 2 to 5% of infants born to women with COVID-19 near the time of delivery test positive for the virus in the days after birth. Only if mothers are severely ill with COVID-19, they might need to be temporarily separated from their newborns. These are the COVID-19 symptoms in children. As you can see, they are no different. No one can distinguish that the child has COVID-19 or some other acute viral disease. So you need a test to prove that the child has COVID-19, but I don't think it's necessary to do such a test to a child with flu-like symptoms, because this changes nothing. The complication. The so-called multi-system inflammatory syndrome in children is an autoimmune reaction related to COVID-19. It's a form of Kawasaki disease, vasculitis, and there is nothing special. This is just a new virus, and this virus causes sometimes autoimmune response that resembles Kawasaki disease. Similar autoimmune reactions can be related to other viruses as well. Swelling of the hands and feet, often with redness, and there are criteria for the diagnosis Kawasaki disease, and if they are fulfilled, child caused by coronavirus. Pneumonia is very rare. The big problem is how to prevent COVID-19 in school children. In my opinion, all children should go to school in person, because online education is a disaster. It's just a very sophisticated way to produce students. The most important things in school are the presence of hot water, washing hands, soap, napkins in the toilets. Hand washing should be advised and even informed. So teachers should, everyday teachers should inform the children that they have to wash their hands. And also, another important thing is to have clean air in the classrooms. About the management of COVID-19 in children. The management should be as in any other acute viral disease. This is caused by a virus, new virus, Fortunately, in children, the course of the disease is slight. There should be limited use or no use of antibiotics. In children who are sick, they need bed rest and proper rehydration, oral mostly, or sometimes intravenous if the child is in a severe condition. Limited use of antibiotics because, as we all know, fever is a defensive reaction, and by lowering the fever, we interfere in the process of healing. And in case of severe pneumonia, which I have not seen in a child up to this moment, I hope I will not, oxygen should be used. And in my opinion, that's all for COVID-19 management in children. Thank you all.
Thank you very much, Dr. Mangarov. If Dr. Andreas Giannoulopoulos can hear us now, he can give his own introductory remarks to our symposium. Dr. Giannoulopoulos, can you hear us now? Okay, I don't think so. So maybe we can continue with the next presentation by Dr. Lambros Lazuras, Associate Professor of Psychology at Sheffield Hallam University, and his talk on the impact of SARS-CoV-2 pandemic on mental health and psychological well-being. Dr. Lazuras, you may have the floor.
Hello, can you hear me clearly?
We can, and we can see you also in your presentation as well.
So great. So what I'll say is that I'll just close my camera, turn it off when I start presenting, so that this is better for the audience, because I gather that there is some disruption when you're using the camera. So I'll just turn off my camera now. And I will proceed with the presentation. So I'm a psychologist at Sheffield Hallam University, and primarily I'm interested in mental health. So today I'm talking to you about the effects of mental health, of the effects of COVID-19, the pandemic, on mental health and psychological well-being. Now, when we're talking about mental health, it is important to understand what this is not just the absence of mental health disorders like depression or anxiety. Rather, we're embracing a broader concept here. According to the World Health Organization, mental health is a state of well-being in which people realize their own abilities, their potential, they can cope with normal stresses in life, and they can work productively to fulfill their goals and contribute meaningfully to their communities. So this is the broader sense of mental health, and today my presentation has to do with both aspects of it. That is, both the presence of symptoms of mental health disorders, as well as this perspective taken by the WHO, how the pandemic has influenced our capacity to cope with stresses in life, with stresses induced by COVID and related measures to prevent it, as well as with the functioning of the society as a whole. Now, why is mental health important? There is a World Health Organization special initiative for mental health. It's a strategy that they want to implement between 2019 and 2023. Of course, the strategy has gone astray as we speak, because one of the goals of the strategy is to improve and support globally mental health. They know that there cannot be health. Mental health is an integral part of what we call health in general, and we cannot have healthy people without them having good levels of mental health. People cannot function when they are not in a good mental health status. So coronavirus pandemic indeed has inflicted mental health globally, and of course it has also inflicted initiatives such as this one by the World Health Organization and many other initiatives taken right now by different national governments across the globe trying to promote mental health. So in terms of understanding how the pandemic has influenced mental health, we need to define two things. One is the populations that we're talking about. So not all people are affected in the same way by the pandemic. And also we need to define the effects. What do we mean by the effects of the pandemic on mental health. Accordingly, if we use this knowledge, then we can inform our intervention efforts, whether they are policies implemented at a regional or local or a national or international level, as well as the preventive efforts for what lies ahead and what would be the future of the pandemic. In terms of defining the population, we have, and sorry, I will not be talking about, based on my personal opinion. I will be presenting evidence today, published studies in scientific journals that have been peer-reviewed. So I'm not talking a lot about my personal opinion, actually not at all. I'm just presenting the evidence here, so what we know so far in the scientific community, because I think that this is a good reference point. So in terms of defining the population, the way it has been defined in the different studies, it has to do with frontline healthcare workers and social care workers as well in different countries. Patients that have been infected with COVID and obviously survived. So how has their mental health been affected after COVID infection? People suffering from mental disorders already, I mean in pre-corona times. People suffering from comorbid physical illnesses, like people with diabetes, cancer, or other chronic conditions, and the general population. Now, in the general population, of course, we can have different segments, people in employees in furlough schemes and financial support schemes in countries, particularly, and I would place a special emphasis there because the evidence shows that they're highly vulnerable to the mental health of the pandemic, and also older adults and people in self-isolation, or what we call in the UK shielded status. That is, people who have to self-confine to protect their physical health. In terms of defining the effect of the pandemic, now we can have an effect that is caused by the pandemic itself, or by the infection itself. So what is the mental health effect on people who have been infected directly with COVID-19? They have contracted the virus and they have survived it. And what are the unintended policy-induced effects? And I think this is important here. And I've noticed in the chat there are a lot of arguments, for or against the masks or social restriction measures. So what I'm presenting here today, it has to do both with infection and those unintended policy-induced effects on mental health. Now, those effects could be direct or indirect, which means that we can have the pandemic influencing directly the stress levels in people, or indirectly having an effect on mental health, like, for instance, reducing the levels of physical activity in the general population, or by increasing unhealthy behaviors like the use of drugs or the use of cigarettes or other substances. We also can have acute versus long-term effects, and right now we mostly report on the acute ones. We don't have sufficient evidence for long-term effects of the COVID pandemic, so there is more to come probably. And we can also distinguish between negative and positive effects. I know that might sound strange and counterintuitive to many of you, but there could be some positive, especially when we talk about resilience and building stronger communities. And I think that Professor Soteriades mentioned something like this in his presentation as well. I will also be presenting some further evidence about this later on. Now, with respect to frontline health and social care workers, this is already a stressful profession. And from what we know from the different reviews of the literature, some meta-analysis papers and reports that have been published in medical and health journals, have acute stress responses in nurses, doctors, support personnel, and people working in hospitals or in care homes specifically. We have significantly higher levels of anxiety, depression, worry, fear, and negative emotions, and sleep problems. And we have work-related stressors as well. And I will show you later on in my next slide what I mean specifically, what health and social care workers report as main problems in their profession. And importantly, we have a spillover effect. Now, a spillover effect is when something is happening in your workplace, this has an influence outside your workplace, like let's say family life. So there is a work-family imbalance evident in health and social care workers, obviously because they're under strain. So the pandemic doesn't take a toll only in their profession, only in their professional life, but this toll it takes also has an effect on their family life and other everyday functioning as well. I don't know how legible is now this slide I'm showing, but it has to do with work-related stressors. So what are the levels of stress reported by healthcare workers, people working there trying to save lives every day during the pandemic. There's lack of control, uncertainty over the clinician status, and increased need for patient emotional support. Redeployed outside specialty, people from different specialties working in different areas that they may not be specialized to work in, increased level of patient death, and how do you cope with this, as well as the mourning and the toll it takes on the families of people who have died of COVID. Of course, prolonged hours, sleep disturbances, bad diet, increase in unhealthy lifestyle overall, and there are more. So the literature indicates that it's not just the stress of the pandemic as a person you're feeling higher anxiety, higher depression. It is also related to the work, the nature of their profession, and it has an effect, as I said, on other areas of their everyday lives. These are some narratives and quotes taken from papers and from anecdotal evidence that were published in media and reported in specific papers, lived experiences and narratives of nurses and doctors. So I broke down and cried today. I cried of exhaustion, of defeat. So people develop the sense of defeat in their profession. It's like they're experiencing burnout, that there is no meaning, no sense in what they're doing anymore. Because after 4 years of being a nurse in emergencies, I suddenly feel like I know nothing. So this narrative, many other narratives, and the lived experiences of nurses, of doctors, and technical support staff in hospitals and in other health and social care services, they indicate how these people who are supposed to be there frontline saving lives, how they experience the entire situation. It's really taking a toll on them, and that toll is in their mental health, is in their professional lives, and their family lives as well. Now, what happens with COVID-19 patients? I want to say that this is news to the scientists involved in the mental health of people who have experienced previous pandemics, maybe not pandemics at this size, but as with MERS and SARS, there is now initial evidence for increased symptoms of post-traumatic stress disorder in COVID-19 survivors. So these people, they have, by and large, experienced their disease, COVID-19, as something traumatic, and this then has repercussions of how they will be experiencing their mental health in the years to come. There's also the prevalence of depression has increased. It's between 40, let's say on average, it's 43% in COVID-19 survivors, and this is a study coming from China specifically about the depression rate in people with COVID-19. Of course, I'm not presenting the entire spectrum of all the studies that have been published. I'm just trying to give you a snapshot based on the scientific evidence so that we all better understand what it means to experiencing mental health problems and what it means to be working under these conditions during the pandemic in hospitals or in other services, and what it is, of course, to experience the infection itself. So what happens to people who had pre-existing mental disorders? It's another segment of the population that has been affected by the pandemic. Evidence for poor mental health support services, especially in countries with overwhelmed health systems. UK is a prime example, for instance, and there is evidence from charities in the UK and from the institutions, official institutions involved in the promotion of health. There will be a need for mental health support in roughly 10 million people living in the UK right now. 1.5 million of those people would be children or adolescents, or people under the age of 18. So we're not just talking about people who had mental health problems before. We might have new patients, new people, more people diagnosed as new cases of mental health disorders as well. As I said at the opening of the presentation, the pandemic does not influence all people in the same way. When we're talking about people with pre-existing conditions, we have evidence of increased severity in their symptomatology in patients, for instance, with anxiety, eating disorders, and obsessive compulsive disorder. There is evidence that people with OCD who are now being treated with medication, their disease, obsessive compulsive disorder, I have to say, is a type of anxiety disorder, is where people are preoccupied with things like cleanliness. They want to be clean, they want to sanitize themselves, they're afraid of being infected, were exposed to germs and things like that. So you can imagine that during the pandemic, all those symptoms, they have been exacerbated. Even if people are confined into their homes, they engage pathologically with self-sanitizing behaviors like washing their hands constantly and using sanitizers. So essentially, the pandemic and the way this has been portrayed in the media, the way it has been reflected in the policies that all of us have to follow every day, it exacerbates specific symptoms in people with certain mental disorders like OCD. When it comes to people with eating disorders, it turns out that these people, they cannot follow a specific routine because of the disruption, so they might engage in behaviors that they shouldn't, like eating more when they shouldn't be eating more, or engaging in purging behavior, restricting calorie intake because they're afraid that they will put a lot of weight because they cannot exercise the way they used to before. So when we're talking about people without existing mental health conditions, but with other chronic conditions, other disorders like diabetes and cancer, we have a lot of evidence from different countries like China, Denmark, Brazil. Some of them shown here in my citations. We have changes in behaviors that are associated with the self-management of diabetes, like, for instance, controlling the glucose levels in the blood and dietary choices. We know that because of the lockdown, people changed a lot their dietary preferences, and this has had an impact specifically on people who try to control blood glucose levels. Increased stress and worry among patients with diabetes as well, and we also have evidence about significantly increased symptoms of depression, anxiety, negative emotions and fear, and traumatic stress and post-traumatic stress disorder symptoms among patients with cancer. I have to stress here, although I'm a psychologist, I should not be talking about medical stuff, but a lot of operations, a lot of typical examinations, they have been postponed or cancelled, especially in the UK. So people who are expected to receive treatment or even medical care and attention for a condition that they're experiencing, they're now just left in limbo and they feel totally insecure. They don't know when the next medical appointment will be available. And when we talk about people with pre-existing chronic conditions, and this increases further their worry and their stress. I have to say that worry is very dangerous. Worry in psychology, in psychiatry, it has been linked. It's like a silent killer. You think that you're worried, everyone is worried. But if worry is prolonged, then it can take a serious toll on your mental health. It also leads to the development of anxiety and depression. It is a cardinal sign of anxiety and depression diagnosis anyway. Children and adolescents, as I said in my opening, at the opening of my presentation, I will pay a special emphasis here. We all know that in most countries of the world that they imposed lockdowns, there was severe disruption in school, attending school. So they could either not go to school, or as we just recently experienced in the UK, almost half of the students, secondary school students in the UK last week, they were sent home because they were supposedly in contact in the preceding days with people who had COVID-19, who were tested positive. So there has been a significant loss of school days during the lockdown. There is significant loss of school days now as well. And this has taken a toll on the mental health of children and adolescents. As I said, in the UK, about 1.5 million children and adolescents will be in need of mental health services over the next few months. And we have evidence globally that there is increased level of depression, anxiety, and addictive behaviors like internet addiction among younger people, especially in countries and areas that were mostly affected by the pandemic, like Chinese adolescents living in Wuhan area, for instance. We have evidence for other countries as well. Younger people are more likely to experience mental health symptoms and mental health difficulties like increased worry and anxiety than adults. Another reason that may contribute to that is the loss of income or the significant reduction in income in their families if their parents or one of their parents or carers have lost their income because of pandemic disruption, or they're in furlough schemes, so they're experiencing job insecurity, as well as a significant increase that has been reported in domestic violence. Right? So we have a summary increases in the mental health problems of children and adolescents. Some of them could be attributed directly to the epidemic, and the others indirectly to the effects of the pandemic on our society. As I mentioned, increase in domestic violence. Mental health in the general population. So overall, if we take into account the published evidence from March 2020 until now, and trust me, it seems like a very short period in time, but there is a large amount of evidence out there. I'm not saying that all this evidence is high quality. This is there is evidence that we can trust. Overall, there is increase in worry, in fear, in negative emotions, poor coping mechanisms with negative emotions, higher depression, and higher levels of anxiety. Loss of hope and optimism, and higher levels of loneliness. And loneliness is a very important factor here, because loneliness is a risk factor for both depression and anxiety. And as I will show you later on in a study that we did in Sheffield, Hallam a few months ago, it has also a negative effect on social functioning. In the UK and other countries, we have 3 up to 4 times higher levels of mental health symptoms as compared to pre-corona times. So there is no doubt that this pandemic, COVID-19, has taken a toll on our mental health globally. We did a study in Sheffield, Hallam during the first lockdown. As you might know, different counties, different cities in the UK are now under lockdown as well. Sheffield, my city, is also under a total lockdown as of today, at 6 o'clock in the morning. So we did a study with colleagues at Sheffield, Hallam University. We examined the levels of loneliness in 100 adults in the general population during the first lockdown. What we found was that we had significantly higher levels of loneliness as compared to pre-corona times, comparing the levels of loneliness that we had there to the ones before corona times on an average of the UK population. Higher levels of loneliness was associated with higher anxiety and lower levels of empathy. Empathy is a trait which shows how much we can understand and feel other people's pain and be willing to help. And importantly, and I think that this is one of the most important findings here, we found that people who experienced more loneliness during the lockdown, they were less willing to help neighbors, friends, relatives, or other people in need during the lockdown. Like, let's say, you have older neighbors and they need some help with the groceries because they're in self-isolation, whether you could help them or to pay the bills. People who get lonelier, they also turn into self-preservation mode. Lonelier people are less willing to help other people. And we shouldn't blame people who feel lonelier, right? That they're cruel or callous. Rather, we should modify the conditions, provide support so that people don't experience loneliness, right? And the thing that loneliness gets people into self-preservation mode comes from at least 20 years of research in social psychology and in behavioral sciences in general. Loneliness is bad for people. Loneliness causes mental health problems, and in the long term, it also impairs social functioning. And as we evidenced in our study in Sheffield, Hallam University, it also influences directly people's willingness to be helpful and prosocial. So it takes out of our humanity, in other words. So what the future holds, of course, we need more evidence and we need high quality studies with proper methodological designs, with proper research designs to understand what are the long-term effects that could be attributed specifically to the pandemic, either directly from infections or indirectly through the measures that have been taken to reduce the spread of the virus, such as social distancing, for instance. We also need high-quality studies to understand the acute and delayed effect of the pandemic, so what the future holds for the next 6 months, 12 or 24 months. And based on this evidence, we should definitely inform policies, services, strategies, and other intervention initiatives. I would like to close with a remark. I'd like to say that there is a lot of evidence right now in the behavioral sciences and in mental health and psychiatry, for instance, in related disciplines of how we can treat people for all these disorders. There is existing knowledge capital. We have great treatment approaches. We just need to put them in practice. Probably our politicians felt that this thing will go away in a matter of months. A lot of people in Greece and Cyprus, especially the Mediterranean countries, thought that with high temperatures it will go away And probably our mental health services were not ready to experience this surge in need, this increased demand for mental health support. I think that we should reconsider, we should rethink, and we should utilize the knowledge that we have already to provide support to the different segments of the population that I mentioned in my presentation. I would like to close my presentation now with a remark by this great guy, Winston Churchill. He said, we shall never surrender when we faced the danger of German invasion back in 1940. I would like to say that we should never surrender our mental health, right? Let's utilize the best of scientific evidence that we have and find out what are the treatments that work. And let's start deploying them because people are in need of mental health support and we need to act now. Thank you, and I'll be glad to answer your questions in the Q&A later on. Thank you.
Thank you very much, Dr. Lazuras, for this wonderful talk. I will now take over Mrs. Eratosari because she had to leave a bit earlier. Thank you very much, Dr. Lazuras, for this wonderful talk on this important topic, mental health in this field of the coronavirus epidemic. We will now try to allow Dr. Andreas Giannoulopoulos to offer his remarks in our symposium. Please, Dr. Giannoulopoulos, would you be able to give your remarks? Thank you.
Καλησπέρα στην Κύπρο. Να ευχαριστήσω πρώτα απ' όλα για την τιμητική πρόσκληση να συμμετέχω σε ένα τόσο σημαντικό συνέδριο. Επίσης, να στείλω τους χαιρετισμούς μου και από όλη την Ελλάδα στο νησί της Κύπρου που στέκεται ως βράχος ακλόνητος και αντιστέκεται πιστό στην παράδοση και στην ιδεολογία του ελληνισμού που από γενέσεως κόσμου αντιστέκεται σε κάθε μορφή τυραννίας. Με την ευκαιρία αυτή του χαιρετισμού σε αυτό το σημαντικό συνέδριο θα ήθελα να υπενθυμίσω και να επισημάνω μερικά αξιώματα και μερικές απόψεις οι οποίες δυστυχώς έχουν ξεχαστεί, έχουν παραμεριστεί. Πρώτον, να υπενθυμίσω ότι η δύναμη του πνεύματος και της επιστημονικής αλήθειας είναι ανώτερη από την δύναμη των όπλων. Το ένστικτο της επιβίωσης είναι ισχυρότερο από το ένστικτο της απληστίας. Και τις υποκράτειες απόψεις και αντιλήψεις που δυστυχώς παραμερίστηκαν και δεν υπάρχουν στα πανεπιστήμια μας. Ότι οι αρρώστιες πολύ λίγο οφείλονται στα μικρόβια, στους ιούς, στους μύκητες ή τα παράσιτα. Πολύ λίγο οφείλονται στην κληρονομικότητα. Κατά κύριον λόγο, οφείλονται στη φτώχεια, στην ανεργία και στην έλλειψη ορθής επιστημονικής ενημέρωσης. Και συνεχίζει ο μεγάλος μας δάσκαλος, ο αξεπέραστος σε όλες τις εποχές. Και στο δεσπόζεστε, δηλαδή οι αρρώστιες προκύπτουν και από τα δεσποτικά καθεστώτα, τα οποία προκαλούν φτώχεια και ανεργία και κατ' επέκταση ανακυκλώνουν την νοσηρότητα. Επίσης να υπενθυμίσω το ρόλο και τον ορισμό του επιστήμονα, ιδιαίτερα του γιατρού, που είναι να αφουγκράζονται τα προβλήματα της κοινωνίας, να εκτιμούν τη βαρύτητά τους στη συνέχεια να τα δημοσιοποιούν και να παρεμβαίνουν στις εκάστοτε κυβερνήσεις δίδοντας τις ενδεδειγμένες λύσεις. Πολύ σωστά ο καθηγητής μας, κ. Sucharit Bhakdi, το καλοκαίρι, κάνοντας ένα σχόλιο και παρατήρηση για την θεματολογία του συνεδρίου μας στην Αθήνα, μου υπογράμμισε: θα αρκούσε να είναι η μόνη θεματολογία η επιστημονική παραπληροφόρηση. Έχει δίκιο ο καθηγητής μας και συμφωνούμε απόλυτα. Όμως, δυστυχώς, ενώ στην αρχαία Ελλάδα είχαμε θεοποιήσει την αλήθεια, είχαμε τη θεά της αλήθειας που κατοικούσε γύρω από τα ασκληπιεία και τα αμφιάρια, δηλαδή από τα τότε νοσοκομεία, σήμερα παραμερίστηκε και οι επιστημονικές μελέτες και οι έρευνες σε πολύ μεγάλο βαθμό είναι διάτριτες επιστημονικά και χειραγωγημένες οικονομικά. Δεν θέλω να καταχραστώ περισσότερο το χρόνο για να μιλήσουν οι καθηγητές που θα πούν τα θέματα τα καθ' του συνεδρίου. Θα ευχηθώ καλή επιτυχία και η πρόταση του καθηγητού Bhakdi, η οποία ήταν και δική μας άποψη, για τη δημιουργία ενός μετώπου επιστημόνων που να σέβονται την ηθική και τη δεοντολογία της επιστήμης με μια παγκόσμια συνεννόηση, είναι μονόδρομος, πρέπει να γίνει τώρα, έπρεπε να γίνει χθες. Μόνο με αυτόν τον τρόπο θα μπορέσουμε να επιβάλλουμε την ορθή επιστήμη με ένα γόνιμο επιστημονικό διάλογο για το καλό της κοινωνίας και της ανθρωπότητας. Σας ευχαριστώ πάρα πολύ.
Dear Dr. Ioannidis, thank you for your remarks on this symposium. I would like to now introduce Dr. Sucharit Bhakdi from Germany, who would like to present his own talk on the topic as presented on the program. I would like to clarify that there is a problem with the connection of Dr. Bhakdi. Therefore, I would have to disconnect myself and try to see whether I will be able to connect Dr. Bhakdi under my name. I'll be back soon. Please give us a couple of minutes to see whether we will be able to connect Dr. Bhakdi to talk. Thank you.
Okay, fine. Yeah. All right. Well, we have some difficulties getting started, and I hope that you see me and you can hear me. So, despite all difficulties, I'm extremely glad to be here with you today. And I want to tell you that I have been to Cyprus once, visiting Nicosia. That was over 60 years ago. And I recall that this was such a beautiful, I have such beautiful memories of being on your wonderful island. I thought that one day I must return. I did not realize that I was going to return in this manner, but I think that the cause of my return is much more important. I immediately accepted the invitation to speak at this symposium of yours because I thought that it was my chance to give back to you the kindness that I received when I visited you as a child over 60 years ago. So I want to try to make a gift to you today. And my first gift is that I want to bring you some very, very good tidings regarding this strange pandemic. Point number one, the epidemic, the SARS-CoV-2 epidemic, no longer exists in Europe. The epidemic came to an end many months ago, and all the news that you are hearing about a second wave is simply not true. I want to tell you, you must not believe it. The fact is that there has been no increase in number of genuine illnesses since May. And there has not been any increase in the number of deaths since May. In fact, both the numbers of true illnesses and COVID-19 deaths have remained at a very, very low level since May. So there is really no need for any one of you to get excited about the numbers that are being spread. These numbers come to be because the number of tests have skyrocketed. And this has been done on purpose, because by increasing the number of tests of healthy people, the number of false positive tests also rises. And this means that the number of cases that you are being told are being registered are mainly false positive cases with no medical meaning whatsoever. So that's the first piece of very good news I want to bring to you. The second is just as important, because looking back at this epidemic and looking at the numbers in a very, very critical fashion, you will realize that this virus has never been the terrible killer virus that people have been telling you it is. Fear and panic mongering has been the main agenda of this epidemic and pandemic. But if you go back and look at the numbers of the infection fatality rate of people under 70 years of age, you will find that the infection fatality rate of inhabitants under 70 in Cyprus and in Europe, and in fact also in America, is in the range of 0.05%. Now, this is minuscule. This is tiny. This is so little that it must be clear to everyone that we have not been dealing with a killer virus. These are numbers that are even lower than the numbers of flu deaths. Seasonal flu kills more people under 70 than this virus did during the last wave, which ended in May. And linked to this are two realizations that are also very, very positive. First of all, these people, also in your country, were infected because infection was genuine. However, these individuals did not die. This means, in fact, that 99% of individuals under 70 years of age were essentially immune in the sense that the virus did not kill them, although the virus did enter their body and did multiply in their bodies. There were true infections, but the infections did not run a fatal course because the immune system was able to deal with these viruses. Now, why the immune system was able to deal with these viruses is not really clear to anyone. We have our own thoughts, and we have put these thoughts in writing. What we have proposed, we is my wife and I, my wife Karina Rice, and we have written this in our book that is now available to you, Corona False Alarm, is that this virus is not really new. The SARS-CoV-2 virus is just a variant, a mutant of a virus that has been with us all the time. So the coronaviruses consist of a large family of viruses that are all related. And the fact is that these viruses are amongst us today. They were amongst us yesterday, and they have been amongst us actually since the beginning of evolution. So they have co-evolved with us, and they just come and go. They visit you, and then they go away again. And this is how a relatively peaceful coexistence comes to be. During this coexistence, our immune system, our lymphocytes, are trained to combat these viruses. They are trained to control these viruses. And once a virus has been controlled, the immune system is strengthened and ready to get on with the next round, with the next virus that comes around. And this is probably what has happened. So the so-called new virus was just a new variant. And the new variant was, in fact, dealt with by your immune system. That's why approximately 50% did hardly get any symptoms, and about 30 to 40% just got very mild symptoms, and only 10% got severe symptoms. But even those 10% that got severe symptoms, most of them recovered. So this means, in fact, that you don't have to be afraid of this virus. Even if it comes again, you don't have to worry about it, because your immune system is going to deal with it. And this also means that you don't need a vaccine to protect you against this virus. Your immune system is already capable of doing the job. And what I'm trying to tell everyone around here in Germany is that if you are healthy, if you've taken care of your lives and not, you don't have coronary heart disease, you don't have lung disease, you don't have cancer, and even if you're 80 or 90, you don't have to be afraid of this virus. It doesn't kill people who don't have pre-existing illnesses. So overall, this is a very good piece of news. And what I'd like to go on to tell you, and this is virtually the end of my main message, is that you know that vaccine development is really in the limelight. Everyone is talking about a vaccine or vaccines that have to come to save the world. This is not true. These vaccines that are being developed will not be helping anyone who is relatively, who does not have pre-existing illnesses. The only people who may benefit from a vaccine are the elderly with pre-existing illness. However, to develop a vaccine for these people would be a very demanding job, very challenging indeed. And certainly a vaccine cannot be developed in 12 months, not even in 5 years. Normally, a vaccine requires about 5 to 7 to 10 years of development so that one is sure that the vaccine is safe and efficacious. So what I'm trying to tell you is that you should not dream about being vaccinated within the next year or 2 or 3. And don't believe it. Don't believe anyone who tells you that this is going to be possible, because it is simply not possible. First of all, for those of you who are under 70, a vaccine that has been developed at this breakneck speed is bound to do more harm than good. You don't need this vaccine. This virus is not going to kill you. And for those who may be needing this vaccine, you want to be damn sure that the pharmaceutical industry scientists have been taking all the care that they need to take care of so that your health is not endangered by the vaccine itself. And this is going to take a long time. So the last piece of really good news is that, looking at the literature, we have wondered that people don't realize that healthy people or people without symptoms running around, moving around in public, there has never been any case of transmission of the real disease COVID-19, which is the pneumonia caused by the virus, by healthy, asymptomatic or pre-symptomatic individuals. There have only been very, very few cases where transmission of the virus by pre-symptomatic people has been probably shown. But in these cases, without exception, those people who got infected never became seriously ill. And this is a fact that has to go around the world, because it's telling you that all these measures that are being done, wearing masks, social distance, staying at home, all this nonsense is being done for nothing. The probable reason why pre-symptomatic or asymptomatic individuals cannot transmit the severe disease is that the virus load that they are breathing out or even coughing out is much too low. You see, the trouble is that the gold standard for saying that you may be infected is that one takes a swab, a throat swab or a nasal swab, and does a PCR. What people don't realize is that the viral load on that swab is always 1,000 or thousands of times higher than the viral load of the air that is breathed out, because most of the virus are just sticking onto the throat. And it's only when you scrape them off with a swab that you get large numbers that you put in your machine and that you test with your PCR. So, in fact, that is probably the reason why it is virtually impossible to contact the severe disease COVID-19 from an asymptomatic or pre-symptomatic person. And having said that, it must be realized that all the measures that are now being implemented all over the world, including in your country, Cyprus, are nonsense. And I will leave you now with the big that I have for you. And this was actually the title of my talk to you, which you may have wondered at. The corona pandemic, the God-sent chance for Cyprus to enter the books of history, the history books. What did I want to say? I wanted to say that you probably have the best chances of any country in this world to turn the tables right now so that this corona pandemic is happening to your advantage and not to your disadvantage. Because, you see, I believe that the agenda that is fueling this pandemic and the fright and the panic has a very, very high goal. But you are not on the road map of this goal. People who are interested in having this pandemic go on don't really care about what Cyprus is going to do. So Cyprus can probably just say, all right, people, you go on doing what you want. We will take another path. And that path, I can tell you, is very easy. Just stop doing everything that other people are doing. Go back to your normal life. And now I'm looking at you, the Cypriots the Turks and the Greeks who lived together on an island and who were on the verge of becoming friends again. I call upon you to get up, shake hands, and say, let us become allies and bring this island within weeks and months to the top of the world. All you have to do is say, all right, we live on one of the most beautiful places in the world. This is one of the few paradises left in this world. And I tell you, people all over the world are looking for a paradise to seek refuge in, to go on holidays again, where they can be normal and see that they're together with normal people. So no more mask wearing, no more social distancing, no more closing of restaurants, open everything, build some nice new hotels. Don't make the same mistakes that Mallorca made. Do this in a very clever fashion and open the shores so that the tourists from Europe will say, this is the new place to go to. Mallorca is gone. Mallorca will never make it back again. And now it is time for Cyprus to surge ahead. If you do this, I promise you, your economy is going to skyrocket. Your whole nation is going to become one of the happy nations of this world. And around you, you will see how the others will start to follow, but it will be to just sit down and do a bit of thinking, planning, and as I said, this could be a golden opportunity for Cyprus to show the whole world. And you know, the Greeks and the Turks were once upon a time the leaders of this world. Now is a chance to have history repeat itself on your little island. And the wonderful thing about this is that it cannot fail. You can only win, because this virus, the moment you see it, through it, you know that this virus cannot kill you and will not kill you. So this is a bet that you cannot lose. You can only win this. And I wish it would be so wonderful if you did it. Our family would be one of the first to come and visit you and spend our holidays. We haven't had holidays since the beginning of this coronavirus, and we have no way to go. We don't know where to go, and we thought Cyprus would be just the most wonderful place. By the way, as a last piece of thought to you, if you you could also think about opening international schools to welcome all those children who don't know where to go anymore, to come to Cyprus, to become world citizens, cosmopolitans. And if you do that, you would also become a center of learning and knowledge again, as Greece was so thousands of years ago. And with that, I want to say goodbye to you and hope so much that I have given you hope and given you some reason to rethink the whole pandemic and find your way. You know, the moment a country like yours gets up and says, we are going to go a different way, we will not follow those large nations, you can be sure that many other smaller nations are going to follow your example and say, oh, Cyprus has shown us how to do it, we will also join them. And then you will be leading the whole world into a happier future. And so I say goodbye to you. Thank you very much. Good luck and God be with you.
Hello. I understand that Professor Soteriades had to be disconnected so that we could listen to Professor Bhakdi. So he asked me to continue with the next presentation. Can you hear me? Okay, beautiful. Let me see if I can share my screen.
Yes, hello. Yeah. I don't.
How does this work?
Where did I
we need technical help here.
I just close it.
Oh no.
Did it work?
One. Let's try something else. That's weird. It seems that I can only share the slides from Professor Lazuras. Let's try once more. Elpidoforos, we need some help. I'm trying to share the screen, but it seems that the wrong. Oh, well, why do we get back to the other slides? Any thoughts? Okay, perfect. Καλησπέρα στην αγαπημένη μου Κύπρο. What I will try to share with you is some thoughts about issues that are pertinent to COVID-19 on models, evidence, risks, how do we choose the best interventions. I think it's interesting that in this symposium you will hear different perspectives, perhaps complementary perspectives. There will be some agreement on some points, probably disagreement on other points. What is my view about COVID-19? And I need to start by saying that I have no conflicts of interest in anything that I will share with you today. Let's go through these statements. COVID-19 is a very serious threat. It is very unpredictable. It is the pandemic of a century. It's similar to 1918 influenza. It is the top cause of death in 2020, outpacing all other causes. And it is the infectious disease that has killed more people than any other in our generation. How many of these statements are true? It is clearly a serious threat. It is clearly very unpredictable.
Sorry, I can't like that.
It is not the pandemic of a century, It is not similar to 1918 influenza by any means. The person years lost with COVID-19 to date are about 1,000th of 1918 influenza, where we had about 50 million deaths, and the average age of death of people was 28 years old. It is not the top cause of death in 2020. It is not outpacing all other causes. For example, smoking will kill another 9 million people this year, like every year, just as one example of a major killer. And it's not even the top infectious disease in the planet. Tuberculosis has killed 1 billion people in the last 2 centuries. It still kills fewer than it did in the past, but it kills about 1.5 million people every year. These are mostly young people or middle-aged people. And lockdown measures for COVID-19, if prolonged or if repeated, they risk killing an estimate of 1.4 million extra people with tuberculosis in the next 5 years. Again, mostly young people who would have done much better as we're managing tuberculosis far more efficiently in the current environment before COVID-19. Now, as I said, COVID-19 is a serious problem. I would not wish to diminish its importance. I think that we need to take it very seriously, both as a pandemic and also as the consequences of the pandemic, because there's lots of things that can go wrong unless we do that. And now I seem to have missed the presentation again. Oh, goodness. Let's see. Okay, we're back. So there are lots of conspiracy theories out there that this is a manufactured virus, that the virus does not exist, that some conglomerate of companies or evil people thought about designing this. And I think that none of that, of course, is true. This is a bioRxiv paper, a preprint that suggested that there's similarity between HIV and COVID-19. And obviously, this is not true. It's not that this is a virus that was manufactured. So we have to get rid of all the conspiracy theories, everything that really gets us out of the scientific rationale of what we're dealing with. But there are issues that even in the best scientific efforts, we have a lot of statements that probably are exaggerated. Let's go through a number of them. 80% of the global population will be infected. Very rapidly so. There's some debate about how many people have been infected already. My estimate is about 10% of the global population has been infected within that first year, and I think that more people will be infected. I think it's unlikely that we will get to 80%, and I will show you some data. Early data suggested that we have a 3.4% case fatality rate with few or no asymptomatic patients. The envoy of WHO to China found very few people who had no symptoms, and therefore, if you think of no asymptomatic infection, that means that the infection fatality rate, the chance of dying if you get infected with this virus, is pretty much similar to the case fatality rate, the chance of dying if you are diagnosed with carrying the virus. Later, the infection fatality rate was dialed back to about 1% or a bit above 1%, but it is still very high. In many places that you will see, especially in media and social media. And based on such calculations, wonderful scientists at Imperial College, very experienced in modeling, estimated that we will have a massacre that would be equivalent to 1918 influenza. So if you run the calculations with an infection fatality rate of 1% or 0.9% and 80% of the global population to be infected, you end up having way above 50 million deaths, including 2.2 million people dying in the US alone. And this would mean that we would have entirely overrun healthcare systems. For example, these are some news stories from reliable news media back in March, where people were thinking that we will be seeing in every single state, in every single country, what we had been seeing in Bergamo or a few locations in northern Italy that were completely overwhelmed. So people were thinking, for example, for California, that we would need another 50,000 additional hospital beds very quickly within a matter of weeks, or in New York, we would need up to 140,000 hospital beds. Now, what happened is that Some places were hit very hard, but nothing close to these predictions came to happen. And what we had seen in Bergamo and a few places in Lombardy, that in a paper that I wrote with the leader of the Italian COVID response, Walter Ricciardi, and my colleague at the University of Rome, Stefania Boccia, we tried to dissect what happened in Italy. We didn't really see that happen again, with some exceptions. We saw most places not being hit at all or hit very lightly, and we saw some places hit more, and a few places really hit enormously and in a devastating way. Our forecasting seems to have fared pretty badly. And this is a paper that I wrote with Sally Cripps from the University of Sydney and Martin Tanner from Northwestern, trying to understand and dissect why our forecasting was not doing what it was supposed to do. And I'm not saying that it was bad scientists or scientists who were not well-intentioned who did that forecasting. I think they had the best intentions and they tried their best tools. We tried our best, but simply our forecasting, all of us, we just didn't manage to get it straight and to get it right. Here's one example. This is 4 models that were produced by extremely prestigious teams, the IHME team at the University of Washington, the Los Alamos team, University of Texas, and YYG. This is the ability to predict not what will happen 6 months down the road, but just predict what will happen next day with less than 10% error. And if you see blue color, this is really close to 0%. If you see red color, this is about 40%, but really not that great. Almost in all days, these models could not really predict well even what would happen the next day, let alone in 6 months from now. If you ask whether these models had at least the right uncertainty, because you can make a prediction that is not right, but maybe you allow for enough uncertainty that your confidence bounds would allow having a value that is within what eventually happens. Even then, you see lots of blue color. The University of Texas model does a bit better than the others, but actually, most of the time, most models, even when we take the wide uncertainty that they incorporate, they would not have very good predictive ability. What we have seen is that some of that failure to predict is due to our mishandling of how epidemic waves for COVID-19 are evolving. For example, this is what is happening in the first 6 months in different places around the world that were hard hit. You can see that if you exclude India and Mexico that were very early in their course, we had almost all the other places follow what are Gomber's functions. They're not exponential functions. They're functions that are sigmoid. They reach a peak and then they're curving down. And even in Mexico and in India, we start seeing that pretty much in the same fashion. When I plotted these curves, it was earlier in the course of the epidemic wave in these places. So that would explain why our models, why our efforts, and of course that includes my efforts and efforts of some of my best friends and colleagues, could not really manage to get a very accurate picture of what would happen. What we have realized, nevertheless, is that there are some solid features about the course of the pandemic in terms of its epidemiological footprint. This is the age distribution of deaths in the first 6 months of the pandemic. So this is capturing the first wave in the places that were the most hard hit around the world. And as you can see, the majority of deaths typically were in people above 80 years old. Typically, the median age of death was very close to the life expectancy for the respective population. Not surprisingly, Mexico and even more so India are different because they have a much younger population, and again, the life expectancy is much lower. If you look at the number of deaths in people below 40, they're really a very, very tiny minority, and even deaths at age 40 to 64 are still a small minority. This has been seen in many different countries, and it's pretty consistently shown if you look at the comparison, for example, of death risk in people above 65 versus those who are less than 65, that the difference in the risk is about 50 to 100-fold. In some US locations, it's a bit less, about 15 to 50-fold, but still, this is a very stark difference. And if you take extremes like children versus 80-plus-year-old, you will end up seeing risk gradients of 100-fold difference in terms of the risk of dying, and pretty much the same applies for severe disease. These are data from a paper published by the Open Safely team in the UK in Nature, separate curves for females and males. Males have a higher risk of an adverse outcome. But again, you see that very steep differentiation of risk as you go across young, middle-aged, and elderly people. If you try to estimate what the death risk is, to translate it to an equivalent of a daily activity, if you take daily commute, driving a car, and you take the first 6 months of the epidemic wave in the most hard-hit places around the world, and you try to convert the daily risk of death to the equivalent of how many miles one would have to drive to get the equivalent risk of death on a daily basis, this is what you get. In most places, the risk of death in people less than 65 years old, even in the most hard-hit places around the world, is in the same ballpark as driving a car for daily commute. Now, there are exceptions. For example, in New York, it's not the average person, but it's more like a truck driver who's driving from Manhattan to Baltimore on a daily basis. But many people do that for a living. So they would drive these hours on a daily basis. And of course, they have never thought that they are doing something that is going to kill them necessarily. If you look at people who are less than 65 and have no underlying disease, it is even better, because the few deaths that we see in people less than 65, most of the time they're associated with substantial comorbidities. If you try to isolate deaths that occur in less than 65-year-olds without underlying comorbidities, then we're typically in the range of less than 1%. You see some numbers that are a bit higher than this, like Sweden is 2.2% and France is 2.6% of all deaths happening in less than 65 without comorbidities. However, the reason for that is that the definition of comorbidities is very restrictive in these calculations. So for Sweden, only 4 comorbidities have been considered. If you were to add other comorbidities as well, the percentage would substantially be decreased. There's also several clinical factors that modulate the risk of death and poor outcome. Some of them have substantial impact on the risk. For example, organ transplantation or severe immunosuppression, or having leukemia very recently, or having a cancer that is not treated yet, or having diabetes that is completely out of control. All of these factors would increase the risk of death about 2 to 5-fold, which is pretty substantial. At the same time, if you're looking at things like hypertension, it doesn't really increase the risk of death. If you're looking at something like mild asthma, it doesn't really increase the risk of death. If you're looking at something like controlled diabetes, it does include the risk of death, but it may increase it by 1.3-fold, so the impact is pretty modest. This is a typical pie of the population in a European country. For example, if you take Cyprus or most European countries or the US, you have a very large share of the population being less than 50 years old. In Cyprus, the median age is about 35. You have a thinner slice that is 50 to 65. You have about 12 to 15 or 17%, depending on what country you're talking about, that is more than 65. And you have typically a slice that is very thin of people who are in a nursing home. In the US, it's close to 0.5%. In most European countries, it's pretty much in the same range, or a bit less or a bit more. Those people who are at nursing home are at tremendous risk. Their risk of dying, if they're infected, 1 out of 4 will die. Those people who are above 65 and have other comorbidities, they're also at pretty high risk. Those who are above 65 and have no comorbidities, are pretty functional, they have some risk, but it's far, far lower. Of course, those who are younger, as I said, they have very minimal risk. Of course, nothing is zero, but it's really minimal. If you translate these numbers to the proportion of deaths that happen according to different age risk categories, this is what a typical pie chart would look like. We see in most European countries that nursing home deaths account for about half of the fatalities, and then about a third of the fatalities is happening in other people who are above 65 They're not institutionalized, but they're high risk. We have also some other people who are younger, as I said, they have very severe diseases, like they have had organ transplantation or they have active leukemia and cancer. They need to be very highly protected, and they are also at very high risk of fatality. But very few deaths are contributing outside of these thin slices at the level of population proportion. As you're very well aware, we had to respond very quickly. And when we first met that new virus and we saw these horrible pictures from Italy and from China, we had to do something. If really it was a 3.4% or even a 1% or close to that, it was something that would infect 80% of the population. That was really horrible. So any measure was justified at that first instance when we didn't know what we were dealing with. Lots of measures were taken involving different forms of social distancing, and some of them went to extremes of horizontal lockdowns. There's hundreds of measures that are included in the bundle of social distancing and lockdown. Their implementation is rather arbitrary. If you look at the way that different measures are implemented in different countries and the sequence that they're implemented or relieved, there's such a vast array of things that can be done that there's really no perfect recipe on how exactly that should be done. There are lots of randomized trials, more than 1,500 ongoing or planned trials on COVID-19. Actually, only 2 of them are on social distancing measures. And what do we even mean by social distancing and lockdown? Is what we do now a lockdown compared to what we were doing in March? Does it make a difference? What exact measures are we implementing? How can we test these measures? All of these are questions that we really don't have a good answer, because we need to agree first, what is it exactly that we want to do? What are the types of outcomes that we want to decrease? For example, do we want to decrease documented infections? I would argue documented infections is a useful indicator, but it doesn't really tell me much. I would feel okay if I have documented infections, but people do not get sick, if people do not get to the hospital, if people do not have to go to the ICU, if they do not die. If I have documented infections, this doesn't mean much. Conversely, I could have documented infections and people could die or be in the hospital or in the ICU. So it's important to understand that the metrics that we are easily capturing are not necessarily those that we want. Another issue is, what kind of outcomes are we interested in? Are we interested on what will happen right now? Are we interested on what would be the effects on our healthcare system, on our society, on health in multiple dimensions, in the midterm, in the long term? We know that many of the measures can be devastating in terms of their midterm and long-term consequences, and they could really kill millions of people, perhaps, if they have to be prolonged. How do we collect outcomes? If you're thinking, for example, about the long COVID syndrome, do we wait for people to come to us, or do we actively seek to try to find out how they feel and what kind of symptoms they have? What is the long-term relevance of all of these measures that we can capture right away? Because obviously we cannot wait for 10 years. We need to act now. What is their cost effectiveness, and what is their placing in context to broader gains and risks? For example, effects on economy, on the environment, on society, health system at large, health with capital H. To answer these questions, we need to understand what kind of an enemy we're dealing with. So a first question is, how widely is this virus spreading? How common is the infection, and also how lethal it is? There's multiple seroprevalence studies that have tried to answer these questions. And some of the early ones came under fierce attack when they found very widespread of the infection and correspondingly low infection fatality rate in the range of 0.18 to 0.28%. For example, the Santa Clara and the Gangle studies came under a lot of fire because many people thought, well, we've heard about 3.4%, we've heard about 1%, maybe 0.9%. How can you come up with a 0.18 or 0.28 even? A couple of weeks ago, I published a paper in the Bulletin of the World Health Organization where I looked at 82 studies with analyzed data, and the median infection fatality rate was 0.23%. So it is really in that ballpark. And actually, if you look at the infection fatality rates across locations, they seem to be pretty different. But if you look within the same location, they're relatively consistent. For example, Brazil always tends to have values that are very close to 0.2, 0.3, 0.4. California is pretty much in the same range. Japan, or India, they tend to be much lower. Louisiana is much, much higher. New York tends to be higher. Spain tends to be higher. So there is heterogeneity across locations, but there's consistency within locations in these different studies. And if you plot the numbers across the impact of COVID-19 in terms of the total numbers of recorded deaths, and that includes both deaths with and from COVID. I'm not trying to differentiate here. It's just deaths that have been counted somehow as having COVID on board. You see that there's almost a linear relationship, meaning that places that were hit very hard, that had lots of deaths, they have also higher infection fatality rates. And this is very easy to explain. It's not a surprise. If you have a location where nursing homes are decimated, as I said, nursing homes, they have 25% infection fatality rate, not 0.25, but 25. It's like 1,000 times higher. So these places will tend to have also an infection fatality rate that will be very high. But it doesn't mean that the vast majority of the population, the people who are not in the nursing homes, would have also a high infection fatality rate. There's other features. There's issues of management. For example, many places used a lot of hydroxychloroquine, and based on what we have seen, hydroxychloroquine seems to increase mortality as a therapeutic option rather than decrease mortality. Other issues of management, whether people were ventilated, how good the healthcare systems were, how well prepared they were, whether they did protect their elderly and susceptible individuals, and so forth. If you put the numbers together, as I said, the median is 0.23%, and I would argue that if you correct for the fact that the vast majority of these studies were done in locations that had the highest death toll, it's probably in the range of 0.15%. So something like 1 out of 600 people in the general population being infected. Among the people who are less than 70 years old, the median is 0.05%. And again, if you do that correction, you'll probably end up with something like 0.03 to 0.04% on a global level, which means that 1 out of 3,000, 1 out of 2,500 people is likely to die among those who are less than 70 years old and get infected. But again, you see that stratification, that the numbers are even better in places that avoided massacres, like nursing homes, and they're pretty high in places that couldn't avoid these massacres. And hopefully, they can avoid them in that second wave that is coming. What we have learned is that COVID-19 is not a single disease, is not a one-size-fits-all. It is something that can vary a lot. It can be much more mild than influenza, and it can be devastating compared to influenza. The infection fatality rate is not a constant. It's not like the gravitational constant or the Km of an enzyme. What we will get at the end of the day depends on the case mix, the population structure, who are the people infected, how people are treated, and many other factors. The good news is that since we know many of these factors now, we can make the infection fatality much lower. So this is how I think we should go. Use this scientific information to try to amend the factors in our favor. The next important question is how many people have to be infected? I wish we have a vaccine next month that can be used by everyone, that is completely effective, that is safe, that everyone will agree to take it, that it has no problems at all. But as you realize, this is not likely to be a realistic scenario. I do believe that vaccines are great conquests of humanity and of medical science, but we need something that will be vetted and tested and proven to be effective and proven to be safe and proven to be possible to use in a large scale before we can say that we have victory. So where would we need to get to stop this thing? Maybe it will not stop ever. Coronaviruses are with us. They stay with us. They come back. They have some outbreaks now and then. We live with them. So maybe that's what's going to become of that coronavirus as well. But how about that first pandemic? Do we need to get to 60%? Do we need to get to 80%? Because, of course, some models even go to 80%. These quotes assume homogeneity of mixing of populations. They assume that I have an equal chance of meeting you in Cyprus, meeting my wife in California, and meeting my mom in Athens. Or, if you are in Cyprus, you will meet with everyone in your city. You have an equal chance of meeting with everyone in your city. And as you realize, that's not the case. populations have some sort of quote-unquote segregation. They're avoiding mixing with everyone for whatever reasons. We mix with some people, we have some friends, we have some people who we work with that we communicate. This means that if you correct for that heterogeneity of mixing, it means that you don't need to get to 60 or 80%. You may need to get only to 10, 20, 30% before that pandemic wave will be pretty mature. The second waves, we just don't know how high they will be. We just need to be prepared for them. We see now that they're pretty high, but in most places, they're not coming together with very high death toll. Does this mean that we have learned something, that we have managed to avoid having them hit the most vulnerable, the most susceptible people, and therefore their impact would be less likely to be as severe as it was in the first wave? Do we have a bonus from other coronaviruses? Perhaps. There's some evidence that 20 to 60% of unexposed population already has some cellular immune responses to SARS-CoV-2, suggesting potential cross-immunity from garden variety coronaviruses. And this may explain why the epidemic waves may stop with relatively low percentages of people being infected, or at least people having less severe disease in many of the new coronavirus infections. So this is something that is still evolving knowledge. Asymptomatic infection, how important is that? It is common. I think that based on what we know now, both my team and other teams have found that a very large proportion of people are either asymptomatic, but still have positive molecular tests, or they have some symptoms that these symptoms are so mild and so non-specific that they just don't get tested. Especially in the first wave, very little testing was done. So we kind of missed all of these infections. Now, are these really infections? I would count them as infections, but we have to differentiate between someone testing positive and calling that an infection because of positive molecular test versus someone who has an infection and is ill because of that infection. Most people who have a molecular test that is positive are not sick, or they're just having some symptoms that are not really affecting them in any major way. They can still transmit the virus though, and I think that about 1 out of 10 of these people could transmit the virus to others. And if you take into account that we have lots of them, you do get to see people transmitting the virus without having symptoms. We haven't really realized that they have SARS-CoV-2 that they're carrying with them. And this is a model that we recently published with Ellen Kuhl from Stanford, where we try to model the implications of asymptomatic infections and try to understand the spread of the virus in the community and also what it means in terms of trying to hold an epidemic wave. We don't want to treat asymptomatic people, but we want to avoid having them spread the epidemic wave to people who might be vulnerable and eventually get substantially sick. How do we do that? As I said, we have no trials about how to do it. We have some trials from the past. We have a trial on masks in people who are infected with influenza, and masks seems to be a good thing for them. We have another trial for people who are treating people or getting in touch with people with influenza. Again, that seems to be a good thing. We don't have really any trials on masks for COVID-19, randomized trials. We have one trial done in Denmark. Apparently, it seems to have negative results. Masks do not seem to work, but the trial has come under scrutiny even before being published. Its design was aimed to assess whether people who are wearing the mask will get a lesser chance of getting infected. And apparently, even though people have not released their data, it seems that they found no benefit. But we're not really doing it for this. We're doing it for people who might be infected from us if we are infected. So I think that we need to be a bit careful about making strong statements about what we know and what we do not know. When it comes to treatments, as I said, we have a flurry of trials, and many people, especially clinicians, desperate to give treatments. They started giving treatments that was completely well-intentioned to try to save people, especially those who are more severely sick. Based on what we know now, unfortunately, some of these treatments are not effective, and some of them may have been harmful. For example, we just this is just the growth of trials, about 1,500 trials launched within a few months. Very few of them have been completed. Many of them probably will never be completed. I think most of them will be abandoned. We have one success. We have dexamethasone that seems to decrease the chance of of death, about 1/3 in those who are very sick. Remdesivir, I'm not really convinced. It doesn't seem to save lives, although maybe it can shorten the duration of illness for people who are in the hospital. This is one international meta-analysis that my team put together with data contributed from 28 teams around the world looking at hydroxychloroquine as treatment. Unfortunately, that's bad news. The risk of death goes up about 10%. And with the latest update that we just uploaded in a revision, it seems to be even substantially significant, not both clinically and statistically so. So we're back to our social distancing measures. We're back to our lockdowns that policymakers are thinking about and contemplating and speaking of, and lots of people are of course, denying to follow because they're very draconian. Do they work? This is from a classic paper in Nature by the Imperial College team. As I said, they're wonderful modelists, and they published the top panels that show here what's happened in the UK, and they run calculations for other countries as well. Their model suggests that lockdown, among all the other measures that were used, lockdown was the one that really managed to get the basic reproductive number down substantially, and eventually save the day, save lives. And of course, if that's the case, we need to take it very seriously, because it may have devastating consequences on other fronts, but if it saves lives, that's really wonderful. Well, Imperial College used also a second model that they also published separately, and they applied it not to European country data, they applied it to states, to American, US states. And we applied that second Imperial model to the European data. And when you apply the second Imperial College model, lockdown has absolutely no benefit, absolutely no benefit. And actually, the fit of that second model is much better compared to the fit of the first model. So that's really very weird. The best fitting model shows no benefit. A very weird, poorly fitting model shows a benefit. What do you trust? Well, we tried other models, and again, we didn't really see much of a benefit with lockdown. What we did see is that people did try to stop some of their mobility. They became more careful. In Greece, for example, they became more careful before the lockdown measures. It seems that their mobility started decreasing, their meeting with other people, their exposures decreased. And this happened pretty much in every country. It happened in Sweden, it happened in South Korea, in countries that did not apply lockdown. So I think that one could avoid exposures, at least heavy exposures. I'm not saying to diminish life and destroy life, but avoid heavy exposures to congested settings where you don't need to be there, and use measures like hygiene, mask when you have to be in congested places with other people, or indoors with many other people sitting next to you that they're not your direct family. But you don't need lockdown. Lockdown is only going to cause harm, and it's going to cause harm in many, many different ways. We saw that already in the first wave, and I think we will see, unfortunately, more in the future if we continue to use that recipe. We've seen, for example, that there was an increase in the numbers of people dying from acute myocardial infarction and other acute diseases because they were not given proper hospital care. People were very much afraid. They were scared. They didn't go to the hospital. You need to go to the hospital. If you have a heart attack, you cannot really stay at home. So this is one easy way, unfortunately, that we saw an excessive death. We saw people with cancers that had delayed treatments because everything stopped because of that pandemic wave that was not coming to overwhelm the hospitals, but people were not getting treatment for cancer. And I think that we will see these deaths coming in the next 5 years because people will not die immediately, but they will die because they had suboptimal care. We had disrupted cancer prevention with pretty much the same impact. We will see these deaths coming in the last 5, 10, 20 years. We had complete health care disruption with postponement of cancellation of elective procedures, regular care, things that do matter. We had suicides and mental health disruption. We have many surveys that suggest that lockdown made 50% of the population depressed or anxious, and about a quarter of young people had suicidal ideation in the US. We had violence. We had, at a global level, the problem of starvation, with disruption in food production and transport becoming a bigger and bigger problem in low-income countries, because if you shut down the economy, you shut down transportation, you really have hundreds of millions of people at the brink of starvation. You add another 200 million people who might be starving in the near future. Tuberculosis, I mentioned that we run the risk of an extra 1.4 million deaths of young people in the next 5 years. Childhood diseases because of disruption of vaccination programs, alcohol disease, other diseases of despair because of unemployment, because of people losing their jobs, losing their hope, losing their lives and their future. We just cannot do that. Multiple chronic other problems, and even destroying our basic healthcare system. The healthcare system needs to be financed. You cannot really find money on a tree. It needs funding, it needs resources, it needs support. If you destroy the economy, we cannot have healthcare. We cannot have primary healthcare. We cannot have tertiary healthcare. We'll have deaths from all other causes accumulating. What the future holds, it's very hard to say. We know that pandemic waves for a new virus, when it is introduced in the community, may take a couple of years to run their course. It's not just 1 week or 2 weeks. I think that many leaders in March thought that, well, I will close the country for a couple of weeks and I will win and carry the day and it will be over. No, this is a marathon. It's something that will last probably at least a couple of years. Actually, with our efforts to stop it at all costs, it's likely to last longer than it would have run if we just happened to be, let's say, in the 18th century, we just couldn't do anything, or had not even realized that it was out there, and then it might stop earlier, but obviously with a potentially higher death toll. So here's a stratification of the global population. We have about 10 million people who are institutionalized, frail elderly people. We have another 250 million for over 75. We have 450 million 65 to 74, another billion of people who are upper risk less than 65, and 6 billion of low risk less than 65-year-olds. 7.7 billion people, if you run the calculations under different assumptions, if we get to 60% of the population being infected, which I don't think will happen, but let's say if we have like the full herd immunity, we have no vaccine, everybody mixes with everyone else, we have nothing to stop it, and we get to 60% everywhere, not just in Mumbai or in some low-income places in Latin America, but everywhere. Then we're talking about 8.8 million deaths over 5 years. As a comparison, seasonal flu over 5 years is about 2.5 to 3 million deaths. And actually it includes lots of young people and lots of children. And these 8.8 million would not include really many or hardly any children or young people. If we get to a 30%, which I think is more realistic, then we're at 4.38 million. I think it's far more realistic. And if we can protect people who are at high risk, for example, if we make them be infected only half the time compared to the low risk people, we're down to 2.28 million, where we're halfway, if that's the case. If we can protect them even more, we're down to 1.58 million, which would be really great because it means that we are at 1.1 million already. Obviously, we've had a lot of mistakes in the early management, and you know, that 1.1 million, we could have avoided probably about half of that. But it's really up to us to decide how we want to handle that. And I think if we modestly protect those who are at high risk, we can really get substantially better outcomes. Of course, there's other factors to affect the toll. Vaccines. I hope that we have them soon, but you never know, and we may never have them, who knows? There's uncertainty about their successful development, about availability, about effectiveness, about safety, about uptake, about coverage of high-risk populations, about impact on transmission, about duration of protection. All of these are pretty much unknown at this time. Maybe we could develop some more effective treatments and management options, or at least avoid the detrimental ones like hydroxychloroquine. The impact of economic and social disruption on the course and management of the pandemic, I think could be really major. If we manage to destroy our countries and the world, then we're not talking about just COVID-19, which might be 0.5% or 1% or a bit more at the most of all deaths. We're talking about 300 million deaths happening for various causes around the world over the next 5 years. We're talking about far more serious problems. Public health and personal hygiene measures, could make a difference. We don't know how much, but I think that we should try to do our best without disrupting society at large. Interplay with other emerging health problems, for example, respiratory infections like influenza. Influenza seems to have disappeared, or at least decreased, in the Southern Hemisphere during the advent of the coronavirus waves. I think people should get vaccinated for this winter, but maybe we don't see also an influenza wave while we see a coronavirus wave. Or maybe we do see one. That's something that we need to see, but I would like to feel that the optimistic scenario is more likely. Reinfection, people are talking a lot about reinfection. I don't think that we see much of that, at least in the short term, and I don't think that it will make a big difference, but we have to track it. Chronic disease, again, something that we need to track, who knows, but I'm relatively optimistic. And finally, catastrophic chaotic events, wars, riots, revolutions, things that are very disruptive. If you get people crazy, if you get them so anxious, if you get them mad, then you're destroying really everything. And we need to avoid that. We need to remain calm. We need to avoid panic. We need to just not think that this is the end of the world. It is not the end of the world, but we can make it become the end of the world if we do the wrong things. So what should we do? I think testing. I have been a very strong proponent of testing in the early days. I think if we test early on, before you have an epidemic wave, then you can contact trace and stop the epidemic wave. But that means that you need to keep going until you have a vaccine, because if you relieve the tension on testing, you will probably have an epidemic wave. But Singapore and Taiwan, for example, were very successful. Singapore had 58,000 infections with only 28 deaths today. If you manage to suppress a wave, you can hope that testing will pick resurgence for a second or a third wave. I have also argued that we need to do very rigorous epidemiological surveillance on representative samples of the population. There's different ways to do that. We can go into the technical details if you wish, but otherwise, if we just wait for people to come to us to get tested, that just says nothing. I mean, if you do more testing, you will get more infections detected, but it doesn't really mean much. Employ the information on the risk distribution. Don't ignore that. We're talking about a disease that is nothing or completely lethal. And we cannot deal with these two extremes in the same way. 90% of people can go along their lives pretty much in a normal fashion. Of course, they need to protect others, but they can live in a normal fashion. 10% we need to protect, 0.5% we need completely draconian measures. Hospitals, nursing homes, hygiene, draconian hygiene, infection control, draconian infection control. Test all personnel, test residents regularly, more frequently in periods of resurgence and activity of the epidemic. We need to protect these people. That's a very small proportion of the population that will need extra measures. We have some other high-risk settings like some types of jobs, meat processing plants, prisons, homeless shelters, ships. For the rest, the vast majority of the population, I would say, live your lives, use hygiene, hand washing, respiratory etiquette, masks whenever they're appropriate, some non-disruptive distancing. Keep living, keep protecting yourself and others, but don't get too anxious and too depressed. Don't get anxious at all, I would say, and not get depressed at all. COVID-19 also is a disease of inequality, and it creates even more inequality. So we need to protect the disadvantaged. If we say lockdown, we think that everybody is sheltering at their happy home. That's not the case. It's wealthy, healthy people who protect themselves. It's people like me who give lectures on Zoom. The poor, the disadvantaged, those who are really sick, they're out there working because they have to make a living. They have to go to work. They are essential workers. They're out in the street. They're homeless. Lockdown does nothing for them. Actually, it victimizes them. It saves me, who I don't need to be saved, and it kills people who need to be saved. Eventually, we should do our best not to destroy the whole world with aggressive measures. Please, I think that leaders need to realize that this is a problem, but it is manageable. It should not be made a far worse problem based on the measures that we're taking. To end, here's my proposal. This is a paper that I wrote with Prabhat Jha from Toronto, and it's coming out next day in Lancet, tomorrow in Lancet Global Health. We are proposing that since we are doing all these crazy measures, we should do something right. If you want to do something really disruptive, during the COVID-19 pandemic, we have destroyed most businesses, most markets, most of the economy, most of our health. We have destroyed everything. Well, let's do something right. Let's take as an opportunity to eliminate the tobacco industry. We can do that, and we go through the points of how exactly this can be done. Just to give you a comparison, Cyprus, for the first 10 months of 2020, more than 1,000 deaths from smoking, 25 deaths with or by COVID-19. Actually, half of them I would have to attribute to smoking, because these people died because of smoking primarily. Many, many thanks to all of you who were here today. Many thanks also to a number of my colleagues from around the world who have participated in some of the research work that I showed to you today. And I look forward to hearing your questions and trying to answer them for those that I know, and learning for those that I do not know. Thank you.
Dr. Ioannidis, thank you very much for this wonderful talk, through which you have comprehensively covered almost every aspect of this global epidemic. It was an honor to have you on this panel of our symposium. I think it's great that we had the opportunity to listen to your talk. I understand that there are many questions on the chat. Obviously, we would have to address some of them, spend some time addressing some of the questions. I would like actually to take the opportunity to pose my own question first, and then we'll address the questions from the audience. I have this concern that a lot of measures are being implemented on this society without having scientific evidence to support it. And under these circumstances, I'm questioning whether even the governments under the power of the state could use their power to implement measures that are not scientifically supported on a global scale, on the whole population. Given that these measures do not have a backup, a scientific backup, how can they apply them on the whole population? Whereas instead, they could actually choose to consider these measures as a research hypothesis and implement them on a small scale under a specific scientific protocol with ethical considerations, and see whether these work before actually applying them on the whole population. So I would actually pose this question. I would greatly appreciate your comment on this.
I think that many of the measures that are being taken are completely meaningless. And I have to say, along with that, that I would never argue that someone should defy the law. So, you know, if a measure is a legal obligation, I believe in the Socratic approach that the law needs to be respected. You know, even if the law is wrong, even if the law is weird, even if the law is giving you poison to die, it's still the law. But I think that many of these measures are like poison given to Socrates. And it's not just poison given to Socrates. They're like poison given to the entire society, to the entire world, to the entire civilization, to the entire life and livelihood. So I would think that people who are in charge should really think very carefully about what they're doing. This is not just an infection. It's a situation that can destroy far more. And these measures have tremendous repercussions. You cannot really shut down the world like that. You're dealing with many reverberations and many repercussions, as I tried to highlight, many of them not very well known because we haven't really done that experiment. I heard about people saying that Sweden is doing an experiment. No, Sweden was doing probably what was the normal expectation. Everybody else was doing an experiment, or at least most countries that went into these severe measures. They were running an experiment that is devastating, to be honest, based on what we have seen now. I'm not going to blame anyone because we didn't know when we had to take these measures. So people asked me back in March when I highlighted that there's a huge danger. So you say that we should not do it. I said, of course, we have no option. It's like we're in the Middle Ages. We need to shut down and stay locked in our houses. But let's get some data. We have these data now. We cannot do that again. I see people talking about lockdown. I'm close to the point of screaming, It's completely unacceptable. We have ways to do things much, much better.
Yes. Yeah. Thank you. Thank you very much. There's a question about masks for children. From your review of the literature, would you comment on this, as well as Dr. Lazuras? Could you comment on masks for children from the mental health point of view? Dr. Ioannidis.
So masks are a highly contentious issue. Masks are effective for people who are infected. They are clearly effective for those people who get in touch. They have to meet and work and be exposed to people who are infected. And based both on work from my team and many other teams, we see that there's lots of people who are asymptomatic. They have no symptoms or limited symptoms. They don't realize it. That includes children. And they may spread the virus, some of them, a small proportion of them. And probably for children, it is even less. It is an even smaller proportion. So there is a risk there. And this is the rationale why masks are being proposed. Children will not suffocate by wearing masks. It's not that they will have physical damage to their lungs, to their brains, to whatever. Is it an effective measure? I think it's likely to be not effective. However, if this is a compromise for children to continue having their schools open and get education and not have that devastating effect of not having education, I'm willing to avoid saying that we have uncertainty and say, okay, let's do it. We want to keep our children at school. We want to socialize them. We want to make sure that they do get educated, that they do grow up really in a normal world with a mask, even though, to be honest, I'm not sure that for children, they're such a great idea. But I'm willing to adopt the lesser evil than the worse evil, which would be not to have education and socialization of our children, and obviously all the disruptive consequences for their parents.
Yes. Dr. Lazuras, any comments on mental aspects of masks in children?
Well, honestly, I can't really tell you because I don't know any evidence saying that it's bad or good for their mental health. But I think that if we focus on the masks, then we're just minimizing the global effect of the pandemic on children's and adolescents' mental health. So I don't think it's the mask that is the problem here, because they don't live in a vacuum and they just ask to wear a mask, So I think it's the entire issue of how risk is being communicated, how they respond to this risk communication, and then what is the overall effect that it has on their mental health. They will not be more or less depressed or anxious because of the mask. Rather, what influences them is the way that we communicate with children. And I mean, it's a great panel here today, really. And I would love to see journalists talking about the ethical ways of communicating risk to the society, and the way that we don't spread fake news, but we should be spreading terror as well. I think that this has serious implications for mental health, not just in children and adolescents, but in the entire population.
Thank you, Dr. Lazuras. Excellent comment on this aspect. There's also a question about the PCR, and I don't know if you would like to comment, Dr. Ioannidis, on the use of PCR, as well as I would like to add another level on that, to focus also on the positive predictive value of PCR, not only on sensitivity and specificity. Thank you.
So it's the first time that we're dealing with an epidemic, a pandemic, with massive use of PCR. We've never done that before. We had other tools. We had indirect epidemiological surveillance. We were trying to get a rough sense of, well, this year maybe about 500 million people were infected with influenza. It could be 10% more, 20% more or less. Now we are trying to capture every single case. I mean, this is both exciting and also horrifying. Because people are just fixating on these numbers, like 10 more cases, 100 more cases, 1,000 more cases, 1 billion cases, and it just makes no sense. If we had epidemiological surveillance that was rigorous, then I would say that knowing the number of infections and active infections would be very useful. In the current environment, I think that testing does make sense because you manage to detect people who have the virus, but as I said, we don't know who are those who are going to transmit, so probably we're quarantining far more than need to be quarantined, but that's okay. I mean, if we just tell people that probably you have nothing, but please stay at home for a few days, it's nothing. There's a slight chance, especially if they're old, with lots of very serious problems, it's not nothing to be exact, but the vast majority of the population, it's just nothing, but please stay at home. But don't commit suicide. We had a 40-year-old owner of an elderly care home in Athens who committed suicide, totally healthy. My goodness, he got a positive test and committed suicide, and this person had zero chance of having really coronavirus claim his life. So I think that we should not panic because of all these tests. A positive test very rarely will mean that you will get seriously sick, unless you are already seriously sick, and this is why you are testing yourself, but then you don't need to get the test to tell you that.
Yeah. And what about the positive predictive value of tests being done on the general population, where we know that the prevalence of the infection is very low?
Yeah, well, it depends on how you define infection. I mean, if you define infection as clinical syndrome, yes, most of the PCR tests mean nothing. They're false positives. But I don't want to see it this way, because it is a fragment of the virus that has been detected. So strictly speaking, it's not necessarily a false positive. But again, it's an issue of definition. We have that genetic material there. Most likely, it will not do anything to you. Most likely, you can just forget about it until you really feel sick. If you want to define it as false positives against clinical infection, yes, the false positive rate is just enormous. It's like 90% or more.
Okay. There's a very small question regarding the infection fatality rate of the flu virus compared to the coronavirus for those under age 70. Do you have information on that?
So as I said, we've dealt with the flu without going through all that super duper super technology PCR globally kind of panic hysteria and science combined. So we don't have exactly the same comparator information for the flu, but we assume that seasonal influenza has an infection fatality rate of about 0.1%. Based on surveillance, that bad years like 1957 or 1968 were about 0.2%. That Spanish flu was sky high compared to that. It was 3, 4, 5%. So the answer that I give to this, if you had a crazy scientist or a criminal who arrested you and said, now I'm going to torture you, you have to choose. You will be infected with influenza, or you will be infected with this new coronavirus. For someone, I'm 55, younger than me, I would say, oh goodness, I don't want to get anything of the two. No, you will be tortured. I would say, if someone younger than me, let's take the coronavirus. Older than 55, I would take the influenza. Up to 65 and even older for people who don't have serious problems, it's not a big difference. But if I were a nursing home resident, if I had severe problems and I was elderly, then coronavirus would be devastating.
Mm-hmm. Yes. There are, we have another channel on YouTube that is broadcasted, simultaneously, and there are a lot of questions from those viewers from YouTube channel about these latest paper that you published regarding smoking. So they're asking, whether you could elaborate even more on that.
So it will be coming out. I said tomorrow. Actually, it's on the 26th.
Okay.
But I just give the example for Cyprus, but you can see it on a global level. Smoking is a $1 trillion business. 99% of the workforce is really being exploited by tobacco industry. They're paid pennies to grow tobacco and process it. And then about 1% of that workforce is making money, big money actually, paid that 1 trillion per year market. And I think that we have accepted that. We have accepted that we have 7, 8, 9 million people dying every year. We are expecting to have like 1 billion people die over 100 years unless we do something. The tobacco industry is growing. The market is increasing by 3%. During the pandemic, they did their best to grow their reputation. They donated ventilators. They said that we're saving the world. It is completely misleading. And we took all these measures. We destroyed everything for very little use, or who knows, maybe for a little benefit. And nobody said nothing. Nobody said, you cannot destroy my business. You cannot destroy my life. You cannot destroy my livelihood. We just accepted it. And we have companies that are making 1 trillion every year out of killing people that are still going on and are even building their reputation during COVID-19. So I think you should read the full paper with Prabhat Zha that I wrote. But if you really want to do something about public health, forget about coronavirus. I mean, coronavirus is a problem. We'll deal with it. We'll get rid of it. Do something about smoking, and something really, really drastic.
Elpidoforos, can I add something, please?
Yes.
Reflecting on the work that we did together about smoking in Cyprus and tobacco control a few years ago, I can remember, and I think that this is a matter of democratic deficit here and political irony, because I can still remember the war that was waged against us when we said there should be smoke-free policies, no smoking in public places, and both politicians and the industry said, forget it, we will not do it. But politicians were ready to accept the lockdown and even destroy livelihoods, the economy, and even mental health for something that was not proven. Whereas we have evidence even for Cyprus that if you implement smoke-free policies, actually the revenues will go up in the hospitality industry. So it's really political irony. I think we should keep these things into perspective when we discuss things like lockdown or COVID, as Professor Ioannidis said, and smoking.
Yeah. This is a great discussion. I really enjoyed. I mean, I wish we could go on for many hours. It's however, I don't see any new questions in the end. So I would like to give everyone the opportunity from the panel to say a last word. I would like to start from Dr. Atanas Mangarov, if he's still here with us, if you would like to say just a concluding comment on this symposium. Dr. Mangarov, do you hear us? I don't get any response from Dr. Mangarov. Dr. Agathangelu, are you with us? Would you like to make a final comment? Yes.
Yes. First of all, I would like to congratulate indeed the distinguished speakers. They were fantastic, and they put the way that we should go further with the pandemic in a different perspective, on more or less on scientific or close to scientific evidence issues. Everything that has been discussed really touched the basic principles, how we should see and how we should proceed with the social issues, with the medical issues, based on what we have at this time in our armamentarium. Dr. Ioannidis, I think, touched everything in a final pathway, saying that we are dealing with a very, very low mortality infectious disease, and we are losing a lot of other comorbidity that they are present in our island, for example, cardiovascular diseases, smoking being one of the critical coronary risk factors in our country as well. And we're investing money in testing people, in having local lockdowns, and I believe that we should start rethinking in the way to go forward with the pandemic measures. Thank you. Congratulations, Elpidoforos, for such a lovely indeed seminar, which we all need, and hopefully this should be transmitted to the politicians, to the policymakers, because they're the ones to be a very good listeners on what we have been said and we have been talked today. Thank you.
Thank you, Dr. Angelou, as well for your support to this symposium. I would like to ask Dr. Lazuras to say to present his concluding remarks.
Well, thank you. Thanks again for the invitation. It's been great to be here with you today. I have to say that whether the mortality rate of coronavirus is high or low, still it's independent of how people have been already affected in terms of their mental health. People are afraid, they have been terrified, and they have intense emotional reactions. In most of the cases, this is manifested as higher anxiety and depression as disorders. There should be a way that we should put this back into perspective, make sure that we have appropriate risk communication. I'm really happy that Professor Ioannidis provided this evidence today that it's not as deadly as it was assumed to be at the beginning, or as it's still believed to be by some scientists. But I think that what we have in it, this is real, is the effect on mental health. And unfortunately, people might be afraid of a ghost, right? But they're still afraid. And we have to do something about it.
Thank you, Dr. Lazuras. I would like to express my full gratitude to all the panelists who have accepted this invitation to be on this symposium. I'm honored to have participated in this symposium, and I would like to give the last opportunity for Dr. Ioannidis to conclude this symposium with his final remarks. Dr. Ioannidis, if you would like to consider at the same time a last question. People are asking about your position on the Great Barrington Declaration. Thank you.
Thank you, Elpidoforos. Great Barrington Declaration. It has been led by some amazing people. I know many of the leaders of the Great Barrington Declaration. They're amazing people. They're extremely well-intentioned. They really want the best for global health, for the health of everyone. And we have some very interesting ideas. I haven't signed it. I haven't signed also the counter declaration, which you know is the John Snow memorandum, where there's also lots of really great people, many friends also who have participated and have signed the John Snow memorandum. I haven't signed that either. And if I had to say, probably I agree about 70% with the Great Barrington Declaration and 30% with the John Snow Declaration. But for each point, I think that it would be a nuanced discussion. And what I really worry is that I see that there is very little tolerance in the community, in the scientific community, when people express different ideas and different positions. And I think that we need to work towards accepting debate, accepting what has been the norm for science all along. Personally, I love to be proven wrong. I consider people who show me that my arguments or my data are wrong and can be improved. They're my benefactors. I don't like, though, the sentiment that it is like a Manchester United versus Liverpool soccer game, that you will never become a Liverpool fan if you're a Manchester United fan. I mean, people need to be able to hear to alternative positions, alternative possibilities. I do believe that, as I showed you with all the data in my presentation, that if we can get a better future and a better outcome, this has to use some targeted precision, shielding, targeted protection. Some people would say this is impossible to do. I would say I think it is possible. The extent is how exactly we implement it and how do we get the most of different measures that could really save more lives, and at the same time, leave our society, our mental health, our physical health, our economy, our life undisrupted. So this is what we should all try to do. You know, rather than fighting each other and writing angry op-eds against each other and trying to come up with conflicts of interest that do not exist for our opponents, I think that we should just try to have all well-intentioned people be free to express their views, do their science, show their data, improve our evidence base, and join forces into doing our best, because there are conflicted entities out there. There's lots of stakeholders who will try to get the best for them under these circumstances where everything is just blown apart. So well-intentioned people, good people, should just not kill each other.
All right. Thank you very much for your wisdom, Dr. Ioannidis, and your wonderful presentation. Thank you all for your participation in this symposium, and hopefully we can move forward with this positive collaboration as Dr. Ioannidis is suggesting. Thank you all. Thank you. Good night.
Thank you.
Thank you.
Thank you.